Hi guys, this is Kristen Lake from Vetmedology, and you are attending treating canine working injuries in the field for veterinary professionals and first responders. Our guest lecturer tonight is Stephen Berkowitz, criticalist at North Star Vets in New Jersey. I have my co-founder with me here, Brian Goldman. Say hi, Brian.
Hi, Brian.
And then we've got Steve Berkowitz here as well. Let's see here. Okay, so let's go ahead and look at some things real quick about some housekeeping. So to earn your certificate, basically, you just need to go to vetmedology.com after the webinar and either create an account or subscribe to Vetmedology for just $10 a month. It's your call. It is free either way to access the CE for the next 3 days. Navigate to the Your CE portal, and this webinar will be available to you to complete the required quiz to earn your free certificate of completion by no later than Saturday, 1/13/24 at midnight. At that time, you will lose access to the course in the Your CE portal if you are not a Vetmedology subscriber. Otherwise, you will have access to all courses and will be able to attend all live webinars for free if you are a subscriber. The webinar will become available on the site by midnight tonight. It does take a little while for the video to go ahead and process. So let's see here. What is next? We have our upcoming live webinars as well. And this is what we have in store for you in February. We have Brian's advanced bandaging techniques in February, and then my the complete guide to medical math for emergency and critical care veterinary medicine. We have ADHD and neurodivergence in veterinary professionals for leadership and support staff, a partnership with leading veterinary teams in Vetmedology in March 2024. And then in April 2024, we have the phone triage masterclass with Shadi Arayfej, DVM and boarded surgeon of Vet Triage. So yeah, we've got some really great things in the pipeline for you guys. So we're going to go ahead and get started with Steve's lecture here. And I hope you guys enjoy the webinar. Have a good night.
Okay. All right. Let me just make sure, are you able to see my slides?
Hang on one second. Let's see here. I'm going to get us off the screen real quick and then get you onto the screen. Let's see. Okay. There you go, Steve. You're good to go.
Right. So thank you everyone for attending. I really appreciate it. This is a really important subject, and just for a little bit of background, as far as the course that I'm going to go through with you, I am honestly the only certified veterinarian in tactical emergency and casualty care through the NAEMT that is a person that went through the course for tactical emergency and casualty care, as well as I am now an instructor for it. And as of right now, there are only 2 or 3 veterinarians in the country that are teaching something like this. So hopefully you enjoy it. I do think it's an extremely important piece for our working dogs. I know these are not animals. These are not only your partners, but your family members. And in a tactical environment, care is very different. Ultimately, the purpose of my talk, we all know what to do once you get to the veterinarian. But the problem is when you're in a mass casualty area or you're deep out in the field and your working dog gets a gunshot wound to the chest or has a massive laceration to the arm or potentially is in a fire, you unfortunately don't have time to get to me. Luckily, where I live, the different Mercer County office, etc., we have a hospital within 20 to 30 minutes of where these working animals are, but if you have a major gunshot wound to your chest, you're not going to make it that 20 to 30 minutes. And so what I'm going to go through with you is genuinely that piece. And the one part that I do want to, point out here. So I do know that we have a very mixed crowd of folks here. Some are handlers, some are law enforcement officers, firemen, EMT, medics, and some people do have the ability to give medications and to do actual field work. But it's very important to know that you need to stay within the scope of your own medicine. Meaning, I can do all these things out in the field that I'm going to talk about, but if you are a human EMT, you have to check with your local area and jurisdiction as to whether or not you can provide some of the care things that I'm going to go through. Your handlers, you're not going to get in trouble from the handlers, but where you might get into trouble is delivering, for instance, ketamine out in the field. For instance, you're covered to do that with people. You may not be covered to do that with these animals. I also want to make a very, very clear distinction between working dogs and family-owned pets. What you are able to do in a mass casualty event is going to be different than what you could do in someone's home. So all of the things that I'm going to talk to you about today, those are related to working dogs out in the field. If you show up to a fire and it's one of the family's pets, don't do any of these things, because no, the American Veterinary Medical Association is not going to come after your license or do anything that way, but you absolutely can get in trouble from those pet owners, because as you all know, people suck. That's why I deal with veterinary patients, because they don't suck, but people are going to try and sue you. So this really only is going to be for your military working dogs or your police dogs, search and rescue dogs. That being said, I just reminded myself, I'm going to try my best not to swear, but I am making no promises to that. I am from North Jersey and I do have a foul mouth. So the few different things that we're going to go through today. I'm going to go through not only veterinary tactical things, but also relate it back to the human field. Again, this course is presented through the NAAMT, and it's for tactical emergency casualty care. So in other words, for mass casualty events, school shooter, bombings, earthquakes. So that's where a lot of this is aimed at. And I'm going to go through some of the terminology and go through some of the things with that. For those of y'all that are on SWAT, for instance, you're going to say, I know this stuff, dummy, I'm cool. But I just want to kind of go through those things with us as well. I will also have plenty of time at the end for questions and answers. So one of the big things that I do want to point out, for those of you that are in tactical training, whether it be TECC or TCCC, which is the military branch, or again as LEOs, we're always taught to disarm the victim, meaning you're out with Officer Smith and Officer Smith gets shot in the leg. The first thing that you want to do is take Officer Smith's firearm away from him. The problem is when you're massively traumatized, you may be lost in the moment and not realize that it's a fellow officer or an EMT or a medic that's helping you. And things can go south very fast. So what you want to do is disarm the person you're working on. Yeah, again, it's friendlies, but friendly fire happens. That is extremely important with these working dogs as well. You have to remember, I don't care how good of a dog it is, the dog is going to be painful. And so, excuse me, what you want to do is you want to disarm your officer. And that dog has a 9mm handgun in its mouth, or 25 blades, whatever you want to call it. So approach the pet with caution, whether the handler's there or not. Remember that this pet is going to be very painful. So the way they react is going to be different than what they're used to. So that being said, it is extremely important for all of us in this lecture to realize, do not separate the animal from the handler when at all possible. Those dogs will die for those handlers, and those dogs will genuinely do anything they can to make sure the handler is okay. And so if we have a traumatized SWAT member, I am going to put a tourniquet on the SWAT member and then get the dog in the ambulance and take it to the hospital with the dog. These dogs are law enforcement officers, etc. They are not going to be told you cannot take them in an ambulance or in the hospital. Vice versa too. If you have an LEO whose animal is shot, stabbed, if you can take that LEO with the dog, take the handler with the dog whenever possible. If both of them are massively traumatized, then yes, take them in separate vehicles, but do everything you can to keep the two of them together. It's going to be safer for everyone, and you're going to have an easier time. So going back to the safety part, if you're in a mass casualty event, these Malleys, the Dobies, they're not going to be muzzled at that time, because when you're walking into that area, it's live action. And so the handler may not even have a muzzle with them. So you have to use what's available in front of you. And so if you look at this picture of this dog, we literally have the dog's own leash wrapped around his mouth. And I would say do a quick double wrap to make sure it's covered. If you cannot get it to stay on, you could always tie it in a knot. You never want to do that in a normal scenario because it can cause trauma to the mouth, etc. But in this scenario, we're just trying to get this patient out of the hot zone. And so whatever you can do to disarm that patient, it's super important, and do what you can. You could use their leash, you can use their collar, you can tear a piece of fabric, just use what you can. Also, it's extremely important for you to know, I've been asked multiple times when teaching this, well, what if the dog is trying to lunge at me? Then in my mind, that dog does not need your help that much right now. If it's trying to attack you, you can't take time to walk and be as careful and calm and quiet as possible. You need to move on to the next victim. So if that dog is being that aggressive, then it doesn't need you right this minute. Okay. And I'm going to go through some of that stuff a little bit later, but those are big things. Another thing that is very important to know that is different with my patients compared to the human patients, zoonosis, or the ability to get an infection from these animals, you do not need to worry. If you get their blood in your mouth, if you get bitten other than it hurting and sucking, you're not going to get HIV, you're not going to get hepatitis. There are only two diseases that you realistically can catch from these animals. One would be rabies, which obviously all these animals are rabies vaccinated. You do not need to worry. The other one would be a bacterial infection called leptospirosis, which quite frankly, the likelihood of that is little to none, but you would need direct urine contact with your mucous membranes. So the purpose of me saying that is you're not going to get sick from one of these animals. All right. And so I want to go through a little bit of their anatomy. What I will say is, for those of y'all that do have a medical background, the anatomy is exactly the same. The function is exactly the same. The organization and hierarchy is all the same. It's just, instead of having your person on two legs where everything is up and down, we now have them on four legs. So just take your person and lay them on the ground, if you will, and everything's going to be in generally the same area. All right. And so if any of y'all are human medics, you will know the term superior and anterior and posterior. I am going to try my best to use both terms, but for us with the animals, we talk about cranial and caudal, cranial being towards the head, caudal being towards their tail. And we usually will not say anterior, posterior, superior, and inferior, just so you know. It's all the same things, it's just a different phrase. So if you look at this slide here, what I'm pointing out to you is exact same respiratory, okay? Their trachea is in the same spot as a person is, their lungs and heart are gonna be in the same spot as well. The difference is going to be where they are actually located. And we'll go through that part. And I am just actually noticing there is one slide that I have that is not in this lecture. essentially what it was is just, it's the exact same picture you see there, but the exception is it gets rid of the lungs and it just shows where the major blood vessels are and where the heart is. But I'm going to point those things out in later slides, and you don't necessarily need it for what we're talking about. So the first slide I'm going to go to is, sorry, I went past that one, is going to be this guy here. And so what I'm going to point out are the major access points to drop IV catheters. But again, out in the field, we don't have time to place a catheter. The reason I'm showing you where these giant vessels are is because that's where you're going to have massive bleeders. And when we're teaching tactical and casualty care, we talk about a direct threat, an indirect threat, and then cold zone. So you'll sometimes hear hot zone, warm zone, cold zone. The warm zone, or the active threat, is when there's an active shooter in your area and or the threat is directly in front of you. In those scenarios, you cannot address the patient. You need to cover, conceal, you need to be out of the way, let the LEOs do what they need to do. And when it's an indirect threat, meaning, all right, there is a shooter in this building, they're not right where you are, but there is a shooter in the building, you need to have your full tactical gear on and everything, that's when we could start to use what we call the March protocol, which we'll go through. But in a direct threat zone, you don't have time to be doing anything. In the indirect threat zone, you're going to work on stopping bleeding, airway, things like that, which we'll go through. And then the cold zone, it's also sometimes known as the evac zone. That's where the threat has been completely eliminated. Potentially you're 300 yards away. But unfortunately, again, coming back to people sucking, when you look at things like the Boston bombing, the bomb that went off, there were supposed to be multiple bombs that went off in 20-minute time frames. The reason is they wanted to hurt all these victims, and they wanted another one to go off 20 minutes later to hurt all the first responders. And so, again, people suck. They plan this stuff out. So your indirect threat or your warm zone could turn into a hot zone very quickly. So just keep your head on a swivel always and be aware that the people that are doing this suck and they're intentionally trying to hurt as many people as possible. So your warm zone, your indirect threat zone can turn into a hot zone very quickly. So again, all these things we're talking about, you're not doing in the direct threat. You're going to get the hell off the X. The warm zone is when we're going to address this March protocol. And so again, if you look at Blueberry, this is my pit bull. He's being used in all these slides because pit bulls have really awesome veins and you could see them without even putting tourniquets and things on. Know that some of these working dogs you're not going to be able to see them this easily. Your German Shepherds, you're not going to see it. Your Malleys, you may see it. Dutch Shepherds, you may see it. Your Bloodhounds, you will. Your Dobies, you will. But some of these animals, you're not going to see these vessels. So that's why I'm bringing my pit bull into the frame so you could see these different things so you get an idea of where they are in a real patient. So what you'll see with Blueberry is the one that's straight down the middle is called the cephalic vein. That's oftentimes where we're going to look to place IV catheters and where you could drop an IV line. And then if you look just to the side, the medial aspect or the one towards this midline, that's called the accessory cephalic. And that is another place where we can drop an IV catheter. Again, in the zone, I'm not asking you to drop a catheter. I just want you to see where these are. So if you have a traumatized patient who's pouring blood, you know where to sort of focus your gaze. So here again, this is Blueberry, and you could see that medial portion or the accessory cephalic on the inside of his arm. Okay. And so again, where you could place an IV catheter, but more importantly, in a warm zone, that is going to be where he's going to be bleeding from in the front. Moving on to his back. So we have on the back legs what's called the lateral saphenous, and that's the guy that runs right around the Achilles heel. So if you see the picture on the right where Blueberry is laying on the couch, because that's where every pit bull belongs, you'll see it popping up right above his ankle. And if you see him standing where he's about to get into the water treadmill, that's where it's going to be on the side. When that, again, is called the lateral saphenous. And here's another picture of Blueberry out on a hike. And you could see sort of from behind where that saphenous vein is, okay? You may see a medial saphenous, okay? Blueberries happens to be very in your face. The likelihood of you being able to see that on the vast majority of working dogs, it's very low. But the reason I'm showing you that is that vein that's going all the way up towards where his penis is, that is tied in with the femoral artery. So you get shot or stabbed there, you're going to have a massive bleed. So you want to focus your gaze on where that vessel is, again, more for that, not to put a catheter in. I mentioned briefly tactical things, right? So we will use what's called a March protocol, also will sometimes be known as XABCs. What the March protocol is designed to do is everything that you have in front of you in a warm zone, what you need to do first to get that patient to survive is stop the bleeding. A massive hemorrhage will kill you in minutes. You may be taught 6 to 9 minutes for an arterial bleed. For those of y'all that saw the video of that hockey player get hit in the neck with the skate, if you actually count Mississippis till he hits the ground, you had 11 Mississippis. He died on the ice. The reports of him dying at the hospital are probably garbage. You will bleed out in seconds. The very first thing you want to do is stop the bleeding, whether it be bandages or otherwise, stop the bleeding. Then we move on to airway, breathing, circulation, great. We could talk about blood pressures, whatever. But the other big piece of the component is the H, the N, hypothermia. Low body temperature will kill your patients fairly quickly as well. And so what that means is you have a patient, you've put the bandages on, you have an IV line, you've given medications, you're now getting them out of the area, you're putting them in a car. All right, well, you need to make sure they're warm. And with your humans, you're told, get them trauma naked, meaning get your shears, cut off all their clothes, get them naked, and then you put them with a warm blanket, etc. Same thing is going to be done with the animals. Obviously, they're not wearing clothes, but if they are wearing a ballistic vest or if they are wearing other things, you want to get those off because blood is cold. As you're bleeding, it gets cold. So you want to warm them up. If you have a vehicle you can put them in to keep them warm, keep them warm. Again, this March protocol is designed to allow you to get this patient to where it needs to be in the fastest time and in the least invasive way to save a life. So March protocol, the XABC is the same thing. It's just instead of massive hemorrhage, it's exsanguination, which is another term for bleeding. So that's where the X comes in. So let's talk about hemorrhage. Again, like I said, you're taught it takes a couple minutes to die from blood loss. Those are all based upon anesthetized patients. Those are based upon control bleeds. Those are not based upon that hockey player that just got hit in the neck. That is not based upon the dog that was just shot in the abdomen and his spleen has ruptured, or who has a lacerated jugular vein. If you take 3 to 5 minutes to try and put a bandage on, you lost your patient. So what you need to do is anything you can to slow down the blood loss and minimize excessive bleeding. And so tourniquets, bandages, pressure wraps, anything you can to get the bleeding under control. In people, we will use cat tourniquets. My face just got really big in my slide. And so I'm gonna do this again. All right. Cat tourniquets are used to wrap around limbs with massive bleeding. The problem is with my patients, you and I have very rounded limbs. Our arms, from our wrist all the way up to our shoulder, they're nice and round. Whereas with a dog, anything above the elbow or above the knee starts to flatten out. So if you feel on your own pet, you'll see what I mean. It's flat. So what that means is those cat tourniquets that you're used to using out in the field, it will do nothing for you out on a dog. You'll see that there is a tactical tourniquet on this Malinois on the bottom right. I will tell you, I've put them on, they do not stay in place. And if you have a massive bleed and you have the tourniquet in place, and then all of a sudden that thing slips off and you're walking somewhere carrying the dog and you don't realize that, well, now that dog is bleeding out on you again. So you can use a fancy tourniquet. You could take the shoelaces out of your boot. You could take their leash, a rubber band, rubber tubing, tear fabric off your shirt, tie it as tight as you can, high and tight. You want to be way above the bleed and as tight as you can. Again, we're going to always tell you in a controlled scenario, don't tie a knot. Tie a knot. Do whatever you can to keep it on tight. You have 2 hours from the application of a tourniquet that's cutting off arterial blood supply to permanent damage to the tissue. Meaning you put this thing as tight as you possibly can. You have 2 hours until I'm concerned about it. Same goes for people. So let's move on to one of our next slides here. And I'm going to move on to penetrating trauma here. So this also same as people, all right? If you have a patient that is impaled on a fence, an arrow like seen with this cat, you need to leave that object in place. That arrow that you see going through this cat may be what we call tamponading or holding the bleeding back. So that arrow may be literally right up against that patient's aorta, and it's the only thing keeping that aorta from bleeding because it's literally stuck up against it. Now, if I pull that arrow out or push it through, now I have a massive bleed in this animal's chest or in a human's chest in the middle of a damn field. So we leave those in place until they get to the hospital. Now, in this particular cat, that is a whole lot sticking out of the cat, and it's going to be kind of hard to maneuver. So what you can do is you can cut part of the piece off, but what you want to do is you want to cut it close to the animal, and you want to hold it right at the base close to the animal, because if you're not holding it as you're trying to cut that, it's going to be moving back and forth inside the body cavity, which means you could be slicing and dicing in there. So what you want to do is you leave the object in place, wrap it, just cover it. It does not need to be a tight thing. Again, you're just sort of covering it so things don't bump into it, so things do not get dislodged. You're just putting a quick wrap. Again, I do not care about bacteria right now. I'm being shot at, or someone just blew something up, or my dog just got half his arm burned off in a search and rescue. I don't care about bacteria. I can worry about that later. I just want it covered, and so it doesn't keep getting full of crap, but you don't need to be super precise here. This picture here of bandaging, I do not expect out in the field to have a beautiful Robert Jones bandage like you're seeing here. The reason I have it here is just to point out you're going to be wrapping circumferentially, so you're going to keep wrapping it around as tight as you can. If it is a small little cut, if it's a burn, you don't want it really tight. It's really tight only when you have active bleeding. If you put a bandage on too tightly for a patient that's not bleeding, then you're going to cause trauma. But what I wanted to show you here is, if you notice, we're starting from the feet and then kind of going up the leg. The reason we do that, I don't know why this happens, but the ergonomics and the kinetics of putting a bandage on, it actually will be tighter when you do the toes up as opposed to the arm down to the toes. I don't have a good answer for why. I suspect it has something to do with the way we maneuver our hands. So that's great for what we call an appendicular injury, or an injury to a limb. All right. But sometimes we'll have an injury to a chest, or we'll have what we call a junctional injury, meaning I can't wrap something around it, again, because that leg is flat. Well, look here. So this here is what we're going to see. This dog, let's pretend, has a penetrating thoracic trauma, right? If I try and bandage just the leg, I'm not doing anything there. So what I need to do is bandage the entire area. Now, for those of you that have ever tried to put a bandage on a dog around their abdomen or chest, you will realize that is oftentimes Not very fruitful, because as soon as the dog takes a step, it falls off, and now they're wearing like underwear around their waist, not a chest bandage. So what you're going to see here, we'll sometimes call it cross your heart, almost looks like a bra. What you're going to do is you're going to wrap around the chest. You're going to go front of one leg, underneath to the other leg, back over the chest, and then back around the other leg, sort of in a crisscross fashion. And again, the purpose of that is you want to be able to apply pressure to that wound. But since instead of this patient being up and down like a person, a biped, since they're on a quadruped, if you try and just wrap it around their chest like you do with a person, as soon as they take a step, that thing is falling off. And even these bandages don't always stay in place. And if y'all that are actually in the veterinary field can attest to that. But the reason those are important is if you look at this dog here. So this dog was what we sometimes refer to as a BDLD, or big dog, little dog. This little puppy was attacked by a large breed dog. He had what's called a flail chest. He had multiple broken ribs in multiple areas. His chest wall was torn open, and he had a sucking chest wound. That bandage that you see on this dog stayed on for 6 weeks. He actually did not need surgery to repair those ribs, and we just did a surgery to close the wound. But those ribs and that sucking chest wound and the hole that were there, we had it just bandaged for 3 days, maybe 4 days before we even addressed the actual wound itself, because the dog was so unstable. So that wrap that I showed you is keeping that from becoming a sucking chest wound, and we're literally keeping it on in a hospital for days. Now, the other thing that's good to know about these chest wraps, when you have rib fractures, when you actually wrap these nice and tight, not too tight so they can't breathe, but tight enough so the ribs aren't moving, it's far less painful. When we had that wrap on that dog, he didn't need much pain medication, and as soon as we took it off, he'd start crying. And as soon as you put it back on, he'd stop crying, and because it limited mobility on those broken ribs. And so that was Mai Tai. Yes, Mai Tai the drink. And the purpose of that picture, again, a good chest wrap is going to help with pain, bleeding, sucking chest wounds, etc. So be comfy wrapping around the dog. Transporting. So I will tell you this, and some of y'all may already know this. These animals are insanely strong and do not react to pain the same way you and I do. What actually got me involved in this whole tactical thing was, now he's a really good friend of mine, Ted. He brought one of his Mallees into the hospital with a broken femur. The dog friggin' walked into the hospital with its femur cracked in half. So looking at these animals outside in, you may have no idea how painful they are or how much is going on. So some of these animals might just walk away. Some of them will not. And so if you have a dog who is unable to use their forelimbs, what you want to do, if you have a sling, great, but who the hell carries a sling into an active shooter position? Get a bed, a sheet, grab one of the sliding guys that you'll sometimes put underneath a human victim to drag them out of an area. Just put it underneath their abdomen towards the back legs, as close as you can get to the back legs. Support the back legs, let them walk out on their front when they can use their front legs but not back. Vice versa. If they can use their back legs but not their front legs, slide it all the way up to their armpits and support them as much as they need. If they are non-ambulatory, meaning not able to walk at all, you can use that same sheet, slide it underneath them. You can use, again, there are a lot of different things, especially the firemen here, firemen and women will know exactly what I'm talking about. Sometimes you'll have the, I believe they call it a scudder. I don't know. You can make fun of me after about that, but you can just slide and pick a patient up. You can use the same thing. And then you just want 2 people holding on opposite sides and carrying them. Again, a lot of these dogs, they're going to friggin' walk out, and then you're going to find out they have a broken back. It's crazy. I don't know how they do it. They're just that much tougher than us. Now, if they are completely unable to walk and you are worried about a proper back fracture, you can put them on a board. You can put them on even the same ones you use with people. But what I want to point out there is restraint wise. He has a strap around his belly. He's got a strap around his chest. That one up top, that is not on his neck. That is on the very back part of his mandible. So if you take your hand and feel the corner of your jaw towards your ears, that is where the strap is. The reason it's there, you have a great ability to lift your head up and down. You have really good, strong strap muscles for that. You don't have very good ability to move your head left and right. What that strap is doing, and if you look below the nurse's arm, it's holding that patient at the jaw. That's keeping the dog from turning and nailing you. Again, it's part of the disarming thing. If you've ever seen a person in the veterinary field kind of put their arm around your dog's head and you're like, what are you doing? Putting them in a full Nelson? No, what we're actually doing is holding the side of their jaw to keep them from being able to turn and tag you. Again, disarm your victim. So don't want you guys tying that around their neck, and I don't want it so they can't breathe. You want it just on the jawline there. Now, if they're not trying to get up and they're not trying to fight you, then you don't need that. Again, at the end, we'll ask questions if that's not clear. All right, so let's move on to fire. So exact same things that you're going to experience in people. The fire itself is not the only problem. With fire comes smoke. And with smoke and with fire and a lot of our synthetic fabrics, so your nylons, your rayons, and some of the low burn crap that they tell you about, as that burns, it releases cyanide, and it also will release carbon monoxide. Both of those things will kill you just as quickly as the burning itself. So we have a couple different things you need to be aware of. One thing, since my patients are low to the ground, a lot of times they have less smoke inhalation than the rescuers that are going in as well, but just know it still is a possibility. But you have the direct smoke inhalation, you have them burning, you have these other parts as well. And so what we discuss oftentimes is when you have a patient that's been in a fire, the reason that you put that flow-by mask on a person's face, it's giving them extra oxygen, but what's actually happening is carbon monoxide, that's the CO, will actually bind to the hemoglobin, the oxygen carrying part of your blood, much, much, much better than oxygen will. And it will literally offload the oxygen from the cells. And so you have a patient who's breathing and they're exchanging oxygen and carbon dioxide, but those red cells are not getting oxygen. They're actually being filled with carbon monoxide. So you're suffocating to death, even though you're exposed to oxygen. But if you look there in room air, the half-life of carbon monoxide, meaning the amount of time it takes for half of the carbon monoxide in your body to leave, is about 4 to 6 hours. If I intubate the patient, meaning put a breathing tube down, so it's at 100% oxygen, it takes about 40 to 80 minutes. If you happen to have a hyperbaric oxygen chamber, it takes a couple seconds, 15, 30 seconds. That's why they're putting the oxygen mask on you, okay? It's not just to provide extra oxygen, it's trying to offload that carbon monoxide. So you're going to want to do that same thing. This next slide is more for knowledge sake. Sometimes we'll use masks and hoods and nasal cannula. What I'm just pointing out there is just the amount of oxygen you can provide. Again, in an active scenario, that's just information to have. It's not really what you're going to be doing. So, all right. We have a patient that's on fire. What's the most important part of that? We want to give them oxygen. You want to put an IV catheter in them. You want to make sure they're nice and cool. No, put out the damn fire. Stop the burn. Do not forget, in these scenarios, especially mass casualty, we have shrapnel. And unfortunately, again, people being assholes. Oh, there you go. I swore. That might be my first one. People being jerks. What's happening is they're using things like phosphorus and they're using things like napalm. And so it's going to continue to burn while it's on the patient, and it's going to continue to burn into their tissue. If you have a smoldering patient, human or otherwise, stop the burn, and then you can address some of the heat injuries. It is extremely important, that word cool water. When we're running a race, what happens is you get really hot, you get really flushed out. If you watch some of the football players in a cold day, they have steam rolling off them. What's happening is you get what's called vasodilation. All the blood vessels out in the periphery open up to get all that heat out of the center of your body. If you put a patient in an ice bath or you put ice cold water on them, what happens is you cause those blood vessels to constrict. So that's vasoconstriction. What happens? All that heat that your body was trying to get the hell away from the heart, lungs, liver, kidneys, you just sent it right back to the core. So do not use ice baths in people or these animals. What you want to do is room temperature water, cool them off, and go that way. Now, if they have serious burns, you see I have thermal blankets there. Again, hypothermia will kill your patient. So make sure that we're making sure they're nice and warm. Obviously, we don't want them on fire, but make sure we're not letting them be trauma naked like a person and freezing cold. Again, I say it there. Here, I've said it in multiple spots. Disarm your patient. Do not forget that their teeth are dangerous. All right, I'm going to quickly talk about CPR as well. So we have what's called a Recover Initiative. Up until the past couple of years, we all were taught things in vet school, what you're supposed to do during CPR, and it's because that's what I did and that's what we learned. The things I'm going to talk to you about are actually similar to the American Heart Association. It's multiple studies, double-blinded studies, and multiple different research. So the numbers I'm going to give you are tried and true, and it's important. So similar to people, we used to learn the ABCs of CPR. That is no longer the issue, okay? Circulation is the most important part of the puzzle. If you're alone and someone in your home dies, or you're alone and your dog its heart stops, you don't have time to put IV catheters, intubate, put tube up, do good quality chest compressions. Now, look at the top of that slide, warm zone. Again, nothing is happening in the hot zone. Nothing is happening in direct threat. You have patients, multiple children, unfortunately, lying on the ground, bleeding. If your first responders start getting shot, now no one is there to help them. It sucks. You're going to walk over patients that maybe you could have saved, but if you get tagged, they have no one. So we're talking warm zone here, okay? What you want to do is good quality chest compressions. We often talk about where to do the chest compressions. When it's a small keel-chested dog where the chest gets really small towards the center, like a greyhound, you would do it right over the heart, which is right behind the elbow. If it's a wide, deep-chested dog, you're going to do it over the widest part of the chest. All of your service animals, you're going to do it at the highest point of the chest. Ignore this picture of the one in the middle and the one on the right. You're going to do it at the widest portion of the chest. All your Malleys, your Shepherds, your Dobies, your Bloodhounds. And the reason you're doing that is if you try and do compressions over their heart, you're not going to generate enough pressure to evacuate all the blood from the heart and then allow it to refill. Now, if you are looking at a deep-chested dog, you're actually not compressing the heart because you'll never get those chambers to open and close. When you're doing it at the widest portion of the chest, you're changing the pressure within the chest. And when you push down, you're causing that blood to leave the large vessels. And when you let go, when you recoil, it refills. And that's why it's super important to remember to allow full recoil, again, with people as well. Because if you're doing it as fast as a damn hummingbird and you're not coming completely off that chest, you're not allowing for what's called end diastolic filling, which just the fancy way of saying you're not giving the heart time to refill itself. So widest part of the chest, and you want to make sure you get full recoil. And then I'm going to go backwards for a second now. If you look at the rate, human CPR, it's 120 breaths. 120 compressions per minute. Look at that. Same exact thing for your working dog. 120, same thing. Compression depth. So that part's going to feel really different to you. Humans have a very narrow thorax. You can put your hands on the front of your chest and the back of your back very easily. If you look at my pitty, you're not going to be able to do that from the front of his chest to the back. So we're doing it from the side, right? like I said, on that through the highest part of the chest. Instead of doing slight compression, you're going to want to compress about 1/3 to 1/2 the depth of the chest. I will preemptively warn you, you're going to be putting more physical pressure than you're used to in a person because of how big that rib cage is. I will also tell you, if you break a rib, I don't care. I can deal with broken ribs and rib pain. I can't deal with a dead patient. So you're going to break ribs. It's okay. It sucks. It sounds awful and you feel awful. I've done it and you want to vomit the first time you do it, but it's not a big deal. I can treat with pain medicine if we get it through. As far as breathing, ignore breathing. You're not going to be breathing for these patients. You're in a hot zone. You need to worry about it. In theory, ideal respiratory rate should be somewhere around 20, 30 breaths per minute. So if you have the patient intubated, you can do that. As you see here, someone's doing mouth to snout. I have another stupid picture here. I'll jump forward. Don't do that. You're going to get tagged as soon as that animal wakes up. It's just not worth it. The one reason I did actually put this picture in, the long part of this dog's nose, if you notice where his hands are, you know those little squiggly wiggly things that are on the side of your dog's mouth? If you try and actually do mouth to nose and you're not holding those closed, all your air is going to go out the side of their mouth. So that's why I actually have this picture here so you can see where you need to cover. Again, breathing is not nearly as important. Quick point, this is also with humans, uninterrupted compressions for 2 minutes. The reason we do that is you're going to have the highest rate of return of spontaneous circulation, but anything past 2 minutes, you start to get very fatigued yourself, and then you're no longer providing good chest compression. So 120 breaths per minute. Breathing, if you're breathing for them, great, lovely. Ignore it in this realm. You're not going to be able to do it for them, but you can breathe for them if you have to. In a patient that has an upper airway obstruction, what you can do is while they're on their side, you can pull the tongue forward and you can see if there's anything back there, check for foreign objects. And the same maneuver you do to pop a ball out of a human's mouth, you can do the same thing in a dog. Again, just be super careful because as soon as you get that out, you're in the firing zone. Quickly, I'm going to show you guys some of the other things. This may not be as helpful to some of the responders here. We talk about placing chest tubes and thoracoscopy. So free air in your chest is really bad. It does not allow your lungs to inflate. So what sometimes we'll do is we'll do what's called a needle thoracostomy, where we literally pass a needle into the chest. Same as with people. In people, where you want to do it is between the second and third intercostal space. You basically take your hand and go to the side of their chest. Dogs, you want to do it, again, at the highest part of their chest. That's where you're going to do it. And so if you look at this picture, this is actually a dog who had a burn. He had a pneumothorax, and that's literally a needle just sticking halfway out of his chest because it's evacuating the air, okay? And if you look at this next picture, this is the same kind of thing. We have everything lined up on the left, so you could see the spaces. It's technically between the 6th and 9th rib space. You don't really need to do that or count that, because if you look at that dog on the right, the widest part of that chest, that's where I'm sticking the needle. That's where I'm doing my chest compressions, okay? As far as airway, again, I will tell you this now. I have 2 slides in here for the tactical casualty care part about needle tracheostomy and an actual tracheostomy. I'm sorry if these pictures are nauseating to people. I will tell you right now, in my entire career as a criticalist and as a veterinarian, which coming up on 20 years now, which is, I'm old, I have not done a single emergent tracheotomy. I have done one where I passed the needle like you see in this dog, for a dog who had an upper airway obstruction, and I just blew air in there, if you will. The actual tracheostomy, you almost never need to do it on our patients. They're able to maintain their airway better than you and I can. And anytime I've placed a trach, including that cute dog on the right, Kevin, it's been while they're under anesthesia. All right, and so these slides really aren't as important to you. This is more for the wet labs that I'm giving of where to place the trach tubes and what they look like. For those of you that do have access to medications, in tactical emergency casualty care, we talk about pain medicine out in the field. What you will be taught is dose of ketamine for a person that has a massive wound is going to be, you start with 20 milligrams. If that's not helping, go to 50. Fentanyl, they're going to tell you to start with 100 micrograms. If that's not working, go to 200. So what that turns into ends up being the exact same milligram per kilogram dose for all of these working dogs. The reason I'm telling you that is if you're about to give 1 ml of ketamine to your person that got hurt, you're giving it to the dog. Same with fentanyl. Now, there's a very important difference between your patients in the human end and the veterinary end. Our patients do not get that respiratory depression that humans get with fentanyl and heroin and things like that. The volume of fentanyl we use in our patients is so much higher than you use in people, and we do not see a problem. Why that's important? Save your Narcan for the handler that is hurt. The likelihood of you giving a dog enough fentanyl or enough narcotic that you're going to need it is slim to none. Save the Narcan spray for your handler. Okay. I am going to switch away from the slides for a few minutes and show you a few different things on my screen, but my email address is there. You can always reach me at any point. I look at email probably more when I'm not at work. So if you have follow-up questions, don't hesitate. And then I am done on my end. Kristen, I am going to switch to just my screen. Are you able to do that for me, or am I just going to the speakers?
Yep, I can do that.
All right.
Let's see here. Hang on one second.
All right. So now it's just my ugly face and screen. Okay. So I just wanted to show you guys a few different things. So I talked about open wounds. When you have a wound that's bleeding, you want to apply pressure. You want to apply as hard pressure as you physically can to stop the bleeding. If you have something like this, so that's called a hemostatic gauze, that has a material in it, usually kaolin or something else, that's going to clot on contact with blood. What you would do is you would pack the wound with this hemostatic gauze, you hold it there for up to 3 minutes, and then you can wrap the wound. If you have non-hemostatic gauze, regular old gauze, or bandage material, or your friggin' shirt, because that's all you have because you were just shot at, you want to hold it there for a minimum of 5 minutes. Now, you never, ever want to take a dressing out of a wound that's bleeding, with the exception of this stuff here. If you are holding it for 3 minutes and you take your hand off and blood's pouring out, take out this thing and put a new one in. Why? Because that means all the hemostatic portion is gone. That is the only time you're ever going to take packing out of a wound, is if you're using clotting stuff. Otherwise, you're going to fill it with as much as you can. You can use plain old gauze material. You can use this, a lap pad. You just want to pack it as tight as you can. Hold pressure for a minimum of 3 minutes with the hemostatic, and for 5 minutes minimum with non-clotting, and then you could wrap it. I will tell you now, if you actually look at your watch and hold your arm for 30 seconds, you're going to feel like it's 2 hours. So just know it's going to feel a lot longer. This here is another example of a hemostatic agent. This is called combat gauze. This is a pretty huge piece of gauze that you can use, and it will help bleeding, but it's also used to stop burning process. So I can put this on a patient who has napalm on it, and it will help get rid of some of that burning and not burn through my damn hand. And then here is what's called a chest seal. Okay. What this does, if you have a sucking chest wound or a gunshot wound to your dog's chest, you literally take this little thing out of the plastic and you pop it on the chest. The exact same thing you're going to use with your human patient. In fact, if you look at that picture, that's a human with a gunshot wound. What this fancy little thing is going to do is it allows air to leave the hole, but not come in. So it's going to prevent what's called a sucking chest wound. It's going to allow air to evacuate the chest, but not get sucked in when it's breathing. I just recently put one of these on one of our patients who had a huge tear in its chest wall from getting hit by a car. And I also put a chest tube in. Once I put this on and we emptied the chest tube, the dog had no free air in its chest for 12 straight hours with just this bandage on. And when the surgeon went in, when it was under anesthesia, the hole was huge and this sealed it. Okay. This is a brand that I like. There's 1,012 different brands out there. You just need something that's going to cover the hole and have a valve to allow it to pop. I will also tell you, if one of these fall out of your IFAC, I was going to say, that's individual first aid kit, then sometimes all you have is like the plastic that it comes in. You can use that too. Okay. Just seal it and tape it. All right. So I know I packed a lot of crap into 1 hour. But I want to open the floor to questions. And again, please know you can email me separately and privately.
Oh, shit. Shit. Let's see.
Did we just lose everybody?
There we go. There we go. Sorry. My fault.
So stop the bleed, pack the wounds, use tourniquets if you have them, chest seals for those open sucking chests. Do not forget to disarm your patient. You're going to get mauled. And if a dog is trying to attack you and you have multiple victims around you, it does not need to be taken care of right this minute. Okay? And save your Narcan. You don't need it for your dogs. You need it for your handlers.
Okay, so we'll open the floor for questions. Thank you so much, Steve. That was such great information. I gleaned so much from that. So the first question is for sealing chest wounds. Does the patient's body wall need to be shaved in the field for the materials to stick?
Awesome question.
Yeah.
So yeah, I actually have in my IFAC, so again, individual first aid kit, a clipper. Do I have one here? No, I don't have one here. It's one of those same electric clippers that I use to trim my face. You can't use a Bic. You can't use like a close razor like that, but you want to do a couple quick zip, 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 zip passes, or else nothing's going to stick to that. But that is a great question. I am an idiot for not bringing that up myself. If any of you have ever tried to put tape on a very hairy animal, it doesn't even stick.
No.
So yes, you do want to do that. And as far as when you're in a tactical scenario, for those of you that have not actually been in a tactical scenario, what I carry is I am wearing my tactical vest and I have a bag that is this big. That's all I carry with me. I cannot carry anything more. In that bag, I have 2 tourniquets, I have 2 chest seals, I have some wraps, and I have my buzzer. So you cannot go into a scenario like that with a bunch of crap on you. So yeah, your clipper should be part of that.
Okay, thank you. So the next question is, will the chest seal actually seal appropriately with the canine's hair? Any advice there? I think we just addressed that.
Yep.
And then another question here is, when placing a chest dart, do you go over the rib to avoid the subcostal artery like in humans?
Perfect question. So you have, again, front to back, cranial to caudal. You want to try and ride in the middle of the rib space, because on the back portion of the ribs, you have an artery, a vein, and a nerve. And if you hit that, it really friggin' hurts. However, I will tell you, I have hit those vessels so many friggin' times when I'm doing a blind tap, pericardiocentesis, thoracocentesis, you do it. Bleeding stops. All bleeding stops eventually. The biggest thing you just want to remember is the chest wall is a little bit thicker than you're used to. However, if you have a really bulky buff guy like Reacher in Amazon Prime, you're going to have a lot of muscle to go through. Just remember, it's going to be similar with these guys. For that question being that you're obviously in the field, you want to use the same 16 gauge 3 1/4 catheter to drop in their chest. Ideally, try and hit it in the middle of the ribs. If you have to ride one of the edges, you want to ride the cranial border or the border that's closest towards the head. Awesome question. But
Absolutely.
Usually these dogs are big enough that you're able to feel literally in between those rib spaces. They're spread out a little bit more than your human victims.
Mm-hmm. Okay. Next question is actually it's a three-part question, and it's really great. Can dogs receive TXA, tranexamic acid, or push dose epi? The second question is, how do you size an endotracheal tube for a dog? And can an IO be placed and where?
Oh, you guys are badasses. So
Good.
some of these, all three of those things are in my tech protocol thing for actual medics. So tranexamic acid, yes, we use it as well. You want to get it on board in the first 3 hours, ideally, and definitely do it within the first 24 hours. For those of y'all that don't know what tranexamic acid and aminocaproic acid do, you have in your clotting system, you make a clot, and eventually your body's going to break it down. Breaking it down is called fibrinolysis. In a certain subset of trauma patients, you have what's called hyperfibrinolysis, where you're breaking down clots way too rapidly. So giving TXA, you're going to give the exact same dose you just gave your soldier, your officer, or otherwise. The thing is, it needs to go IV. So if you're able to get an IV line in, you can give the exact same dose. As far as epi, yes, you can give epinephrine IV during CPR. For a dog this size, we usually say 0.1 ml per 10 kilograms. So you're going to want to give around 0.3, 0.4 mLs of your epi. Endotracheal tube, if you're going to carry one, I would carry a size 6. That will fit in the vast majority of these animals. It's going to be a little small for some, but I'd rather it be small than too big. It won't cause tracheal trauma. So TXA, yes, you can use it. Use the exact same dose volume you would for yourself. Endotracheal tube number 6, epi between 0.3 and 0.5 mLs. I think that was everything. Did I answer all of them?
Nope. We've got the IO one. So locations for IOs. Yeah.
So yes, you can use the easy IO. What I would do is choose the middle size one, not the really big bulky one, because you'll end up going through the other side of the animal. The quickest and easiest place to hit on these guys are going to be on that tibial crest area, so the flat part of their shin. Just feel where their knee is, feel where their ankle is, and go in between them and find the flat ridge, and you're going to go right there. The other place that I'll sometimes do it is at the greater portion of their trochanter of their humerus bone, which if you take your finger on yourself and feel where you feel the bone and no muscle or anything around it, you're going to go right there. Same exact place in a dog, but instead of going here, you're going to want to lift the animal's arm up, and I am completely blocking my camera, and kind of go down that way towards their elbow. It's a little different angling, but it's the exact same spot. So those are the two places you want to go. Hitting the one in the wing of the pelvis, don't even bother trying that. Go for the tibia and go for the front of that shoulder. Yeah. And again, use the middle size one, not the gigantic one, and don't use the little one, because the little one, you're not going to get into the core on these big dogs.
Yeah, the IOs for the humerus, if compressions are taking place, that's not the most ideal spot. The tibia is where you want to go. 8 seconds, easy IO, it's in. Okay, so let's see. Another question here. For sealing chest wounds, how much better do you find the specialized packs versus the saran plastic wrap? Does it make a huge difference from the time it takes to just get to the hospital?
The answer is it doesn't make a damn bit of difference in that scenario. You want to seal the wound. If you're using the saran wrap trick, just remember every now and then you're going to want to burp that. If you're starting to see that your animal's in a lot of respiratory distress, just peel it back and burp it and then reseal it. If you're using these chest seals like this guy here, where they have little, let me just hold up the back part. You can almost just barely see the little channels in there. That's going to keep you from having to burp it. But I don't care what the hell you use. You have a friggin' hole in this dog's chest. Put whatever you want on it. I don't care what you put on it, and just keep reassessing your patient.
Amazing. Does anyone have any other questions that they want to submit before we go ahead and kind of close up for the evening? We'll give you a couple of seconds here to get them in.
Again, if you have more specific questions about dosing and sites and things like that, please reach out. I do have extra slides on it. It's just this particular presentation, I was addressing a lot of different things, from those that are just handlers all the way to full-on EMTs and physicians in here. So I just didn't want to bore everyone with huge dosing things, but I'm more than happy to go through those with you.
Okay, well, it looks like we've got all the questions answered. So I'm just going to go ahead and review for people that may have come in late. In order to go ahead and receive your certificate tonight, just go to www.vetmedology.com and either create an account or subscribe to VetMedology for just $10 a month. That's not necessary. This is a free CE. Navigate to the Your CE portal, and this webinar will be available to you to complete the required quiz to earn your free certificate of completion by no later than Saturday, 1/13/24 at midnight. At that time, you will lose access to the course in the Your CE portal if you're not a VetMedology subscriber. The webinar will become available on the website by midnight tonight. It does take a little time for the webinar video to go ahead and process, but we will get that up for you tonight. And we've got our upcoming webinars as well. In March, we've got Brian's advanced bandaging techniques, and then the complete guide to medical math for emergency and critical care veterinary medicine. This is going to be a very lengthy webinar, but it is going to be all inclusive. And then in March, we've got ADHD and neurodivergence in veterinary professionals for leadership and support staff. It's a partnership with leading veterinary teams in vetmedology. And then in April 2024, we've got the phone triage masterclass with Shadia Rafej, DVM and boarded surgeon of vet triage. So let's see here. All right, guys, I think that's going to go ahead and wrap things up for tonight. Don't forget to take the survey on the right-hand side of your screen before exiting to vetmedology.com to create your account. So your feedback is important to us. We hope you really enjoyed tonight. We really enjoyed bringing this information to you. This was such great information. Thank you so much, Steve.
Of course. Thank you, everyone, for your service. I really appreciate it. And I will get on my soapbox for a moment. Mental health, super important for all of us, okay? Everyone in this lecture has seen some really bad things. And those of us that are in the field, you have to talk to each other. No one knows what it's like to experience the things you experience other than each other. You're not too tough to have the conversation. I'm on antidepressants. Multiple people in my hospital are. We have these talks, because if I don't have this talk with my group of the service dog that belonged to a veteran that just died in front of him or her, I'm going to break down. You need to talk to each other. Please don't be afraid to talk. Your mental health is just as important as your physical health. So please just be open with each other. You never know how much someone needs just to hear it. Never mind, have the talk.
Right. Thank you so much. That was so nice, Steve. Okay. You guys have a good night. And if you guys have any questions or concerns, you can reach me at Kristin, Kristin, at vetmedology.com. All right. Take care, everybody. Have a good night.
Have a nice night. Thank you.